risk factors for lung cancer, smoking is the first, followed by the domestic use of biomass fuel, exposure to asbestos, genetic factors, chronic disease such as EPOC, asthma or emphysema, and of course, environmental pollution. Also included are infections by mycobacteria, pneumonia, and recently viruses such as HPV, Epstein-Barr, and measles. Although their association has not yet been fully elucidated, it is also important to remember the COVID-19 pandemic and to point out the high risk of infections in cancer patients, in addition to the increased risk of complications and death, especially in those with lung cancer. SARS-CoV-2 also produces an exacerbated immune reactions and lung lesions that could induce tumorigenesis in the long term. Cytokines released during infection included IL-4, IL-6, IL-10, IL-35, and TGF-beta, among others, which promote tumor growth, progressions, and metastasis. Overall, 64% of cases were diagnosed in men and 36% in women, as shown in the figure. People aged 45 to 69 years had the most reported new cases, followed by people aged 70 and older and people aged 20 to 44 years. So, the lifetime risk of developing lung cancer in people aged 0 to 74 years is 1 in 19 men and 1 in 37 in women. A total of 257,293 people died from lung cancer in 2020, 66% of whom were men and 34% women, as seen in graph 2. So, lung cancer is the first cause of death due to cancer in men and second in women, but in Europe and worldwide. The 3 EU countries with the highest incidence of lung cancer were Hungary, Ireland, and Belgium, while the countries with the highest incidence of death due to lung cancer were Hungary, Poland, and Croatia. Although the molecular perturbation caused by some infection agents leading to oncogenesis are well known in several tumor models, including cervical cancer, stomach cancer, head and neck tumors, and some types of leukemia and lymphomas. So the pathogenic role of viruses has not yet been well established in lung cancer. However, evidence of the integration of viral DNA in tumor cells and epidemiological research based on clinical studies and several meta-analyses suggests a possible causative role for infectious agents in lung malignancies. Smoking has a potential role in increasing the susceptibility of lung tissue to viral infections, in addition to affecting oncoprotein functions. So, studies in mouse models show that tobacco smoke alters the immune response, contributing to viral pathogenesis and leading to lung function deterioration. The first virus I will talk about is HPV. Various data and reports suggest a role for HPV in lung cancer, but the possible role of HPV transmission to the lung is not entirely clear. Increasing trends in oropharyngeal cancer is in men and women worldwide may suggest a possible route of HPV transmission from the oropharyngeal airways to the lungs, closely related to smoking. In addition, some reports show that non-smoking women with HPV infection have an increased risk of lung adenocarcinoma. Different types of HPV have also been detected in peripheral blood, highlighting a possible route of hematogenous transmissions. HPV has been detected in salad breed condensates from lung cancer patients, but further studies are needed to confirm these preliminary findings. In second place, we have the ABV. ABV is associated with a particular subtype of primary lung cancer called pulmonary lymphoepithelioma-like carcinoma, which affects younger non-smokers with greater frequency, particularly in the Asian populations. Interestingly, ABV has also been reported in patients with lung SCC and lung adenocarcinomas. However, an accurate picture of the epidemiology of ABV infection in lung cancer is far from a reality due to the small number of cases reported and the variety of techniques used to detect ABV. Current data suggests to ABV latency might facilitate the progression from chronic lung disease to lung cancer and vice versa, as previous cell alterations are required precondition for establishing latent ABV infections. In third place, we have HIV. People living with HIV have an increased risk of developing lung cancer with respect to the general population. Factors such as a dysregulated pulmonary immune environment, the development of chronic immune activation, chronic inflammations, despite the use of antiretroviral therapy related to HIV infections, and factors such as heavy smoking can increase the risk of lung cancer in PLWH. In fourth place, we have the CMV. Recently, the involvement of CMV in the pathogenesis of lung cancer has been subject to strongly relying on oncomodulation through the oncogenic proteins PUL123, PUL122, and PUC2A. So CMV remains for long periods in the latency stage and might reactive intermittently through the lifespan. This promotes chronic inflammation and is linked to genomic mutability and a state of immunosuppression in the host, which can lead to the start of neoplasm. However, there are no reports pointing to direct relationships between CMV and lung cancer, even though CMV has been found in a variety of epithelial tumors such as those of the colon, breast, ovaries, and prostate, as well as in salivary gland tumors, hepatocellular cancer, neuroblastoma, and brain tumors. And finally, we have the JSRV and JCV. In humans, JSRV infects the cell surface hyaluronidase 2 receptors. In 2000, they suggest a possible link between JSRV and human lung adenocarcinomas. They also detected the presence of the JSRV-NB protein, an oncoprotein capable of inducing neoplastic transformation in vivo and in vitro in human adenocarcinomas. Furthermore, they found JSRV in kerosene sections of bronchoalveolar carcinoma from patients from 2 Italian regions. However, several studies published in recent years have failed to demonstrate a direct link between JSRV and human cancer. JCV has been detected in several types of human tumors, suggesting has the ability to infect a wide range of cell types. JCV has been found in lung tumors, although there are few studies. However, experiments in transgenic mice have shown that this virus has the potential to cause bronchial tumorigenesis. Prevention of infection by oncogenic viruses is complicated by the fact that, except for HPV, there are no approved vaccines for the above-mentioned viral agents. However, there are no data to support a decrease in the incidence or risk of lung cancer in the HPV vaccinated populations. Once viral infection is detected, there are some strategies to prevent viral activations in order to block or decrease oncogenic transformations. In ABV infections, a smoker should be advised to stop smoking as a primary prevention measure for upper respiratory tract carcinomas. This reasoning is also appropriate for the prevention of lung cancer. The COVID-19 pandemic has had a major impact on global health. Despite all the research carried out in record time, much remains to be determined, especially with regard to the complications and long-term sequelae of severe SARS-CoV-2 infections. Possible virus-induced damage to the lung, cancer, pulmonary fibrosis, hypoinflammation frequently experienced by patients with severe COVID-19, and downregulation of angiotensin-converting enzyme 2 could be implicated in the possible development of lung cancer. However, there are few studies on the short and long-term sequelae of severe infections. Thus, a worldwide scientific and public health effort is needed to further investigate and try to prevent the possible development of lung cancer due to SARS-CoV-2 infections.